Welcome back. So again, a reminder that typically this has been the lecture on suicide has typically been about half a class because neurodevelopmental disorders was 1.5, and then I added suicide at the end of that. And I know you guys already covered this in Intro to Abnormal. It's a required part of 2285. And I also know that given where we live, the society we live in, there is a very good chance that many of you watching this will have had some sort of experience with some aspect of suicide. Hopefully not directly, hopefully not you yourself, but certainly amongst friends, family members, other people who you know or care about. So this can be a pretty emotional lecture. It doesn't help that some of the videos that I'm going to have you watch at the end are like really heavy and really difficult to sit through. Sorry, but not sorry, because this is something that we have to do, right? You guys are fourth year psychology majors. Many of you are headed into jobs in the human services domain of some sort. And as uncomfortable as it is to talk about suicide and think about suicide, particularly if we've had firsthand experience, it's also something we have to learn to be okay with, because working in the human services field, it's going to come up. Now, I start with all this because one of the things I've learned over the years of teaching and talking about suicide is that this is one of those times where I have to actually share more about my personal life than I would like to. And the reason I realized that was because of a pretty significant faux pas I did the first time I taught about suicide. So in my family, I have had 3 family members commit suicide. 2 on my dad's side of the family, 1 on my mom's, so it comes from both sides. The 2 on my dad's side, I did not know. It was my dad's cousin and then one of her sons, who I believe it was about a month after she committed suicide, truly felt like he couldn't live without her, and he suicided. I never knew them, so I always knew about it because at large family gatherings, there was this guy, Stuart, who wasn't related to any of us, but he was always there, and like by the time I had cognition of it with his second wife, and I was always like, why is this guy who we're not related to, who's married to this woman that we're not related to, always at these family gatherings? And my poor parents would repeatedly have to tell me until it stuck that that was the widower of my dad's cousin who had suicided and the father of the teen who had suicided. And I was like, oh, right, okay. The suicide that happened on my mom's side of the family was a little different. It was one of my mom's first cousins, but I knew him. And I was 11 or 12 when he suicided. So old enough to have a little bit of an understanding, but also at an age where the impressions and what I learned from watching how my family was reacted really influenced how I approached suicide later in my, not that I approached suicide by attempting suicide, but thinking about suicide as a clinician and thinking about it as someone who's teaching about it. And that one, in part, stands out to me for 2 reasons. Number one, and this is going to sound awful, but again, I was like 11 or 12. My mom woke me up for school and told me she had some bad news, and opened with the fact that my grandparents weren't going to be able to come to my dance recital because my cousin Harvey had committed suicide, and they would be comforting and being with his parents because his mother and my grandmother were very close. They were sisters, and they were very, very close. So what sort of stood out to me the most as a self-centered 11 or 12-year-old was, oh my God, my grandparents have never missed any of my anything. I can't believe they're going to miss this. And then I felt bad about my cousin, right? It's, again, the way I processed at that age. The other thing was my cousin Harvey had never been happy for as long as I had known him. And for as long as anybody in the family had known him, which was significantly longer than me, because he was closer to my parents' age. He had been diagnosed with what then was the diagnosis of manic depression, what today we would call bipolar disorder, and he suffered from very, very profound episodes of depression. And he had tried everything, inpatient, outpatient, medication, various programs, was seeing a psychologist and a psychiatrist regularly, and it just wasn't doing it for him. And he ended up suiciding. And everybody was sad, but everybody was also a little bit relieved that he wasn't suffering anymore. Because for his whole life, all anybody ever saw was him suffering. And so I, again, being young and seeing that and hearing that from my grandparents and my parents and my cousins, internalized that, like, well, if someone is really that miserable, maybe it's okay. And I carried that view until I got to graduate school. And during one of my PhD level clinical classes, just before they were going to actually give us clients to work with, it's a very exciting time as a graduate student in clinical psychology, we were having the discussion of what do you do if a client is suicidal? And me being me, I raised my hand and I'm like, well, if they're really that desperate, who am I to stop them? And my professor looked at me and said, the psychologist, it's your job. We're going to talk after class. So then I had to talk, in the way I'm saying it, right? Like I was reprimanded for having developed my own views about suicide. And I wasn't. She actually handled it beautifully. And what she left me with was, you may, as a person and as the family member of somebody who suicided, believe that if someone is really that miserable, that might be a reasonable alternative for them. But as a psychologist treating people, that cannot be your view when you are the psychologist in the room. When you are a psychologist, your job is to preserve human life and to enhance human life. And so if you have a client who you think is suicidal, you act on that. You get that person hospitalized. You deal with it. And I was like, oh, okay, that makes sense. And then she looked at me and said, and also, we're not giving you anybody suicidal for at least another semester, right? We're going to make you really, and I understood, and it made sense to me, right, that yes, as a psychologist, as the person treating someone, absolutely, you do not want to see them suicide. And I had to reconcile that with my own personal experience. Now you might be thinking, okay, Carrie, why are you telling us all this? Well, the reason I'm telling you all this is because, again, try to remember that I was like 11 or 12 when my cousin suicided. Also, new little tidbit, my family is very big into gallows humor. My family does not, the way they cope with death is by joking about it. So I was young, death, a family who copes by joking. So the first time I was talking about suicide in class, I happened to mention a particular method of suiciding, which was the way that my cousin Harvey suicided. And I talked about it in very light, kind of funny way. Well, after class ended, I had a student literally follow me, like way too close in these days of social distancing, back to my office. My office was just down the hall from the classroom I was teaching in. And she stood in the doorframe of my office and said, you said something in class today that I found really offensive. And I looked at her and I said, well, that could be any one of many things. You're going to have to be a little bit clearer about what I said that was offensive. And she said, well, when you talked about that way of suiciding, that was really upsetting and really offensive. She's like, that's how my grandmother suicided. And I was like, I am so sorry for your loss. I'm so sorry that you've had to experience that. I said, I talked about it that way because that's the way my cousin suicided. And she went, oh, okay. And then after she left, I went and talked to one of my colleagues, another faculty member in the psychology department, and I said, so I screwed up. And she said, well, you did. I was like, gee, thanks. Tough love there. She said, but how are you going to do it differently next time? And I said, I don't know. I said, like, I have to talk about suicide in a lot of the classes I teach. I don't really know what the best way to do this is. She said, you know what? You have to just be honest. You have to share with people your experience so they have a frame of reference, so that if you do something inappropriate again, they at least know where it's coming from. And so this is what I have in my notes as my standard caveat about suicide, my personal views, my family using humor to cope. And it's just really important that I share that with you, not because I need to share tons of information about my life, but because that may frame some of how I talk about stuff and what I talk about. And please know that if I do say something inappropriate, A, it's par for the course. I say something inappropriate almost every class. B, it is definitely not coming from a place of malice or of not taking this seriously. It's just that's where I'm at, okay? I told Ian we'd go dark, and boy, went darker than he thought we were gonna go, and we haven't even started. We're still on the title slide. You just wait and see. Okay. So let's get into talking about suicide. The first thing we have to put on the table are some definitions. I will also just say, as another little aside, the nice thing about doing this filming is nobody has yet raised their hand to say, so how did you talk about suicide in inappropriate ways? Because inevitably, in a live class, somebody always asks that. I am not going to say that on a video recording that should not be being circulated, but hey, you never know. But during discussion group, if your inquiring minds need to know, make sure you bring it up, okay? I'll give you that. So we have to start with some terminology when we're talking about suicide, because just the word suicide itself, when we say it, people get all tensed up and like, oh no. But yes, oh no, but we also have to consider that there's sort of different pieces of the suicide puzzle. The first is suicidal ideation, thoughts of killing oneself. And I would say, for the vast majority of people, if you are at a point in your life where you are thinking about killing yourself and you're starting to think about ways to do it, that is a giant red flag that you need to reach out to someone else, okay? If you find yourself thinking about means and plans and thinking about timing, you call 911, you call the distress center. Oops, I said it. Oh, good, my phone didn't respond. Because that has happened to me in class before, actually, one time. I didn't say the magic 4-letter word to get my phone to respond. That might be what just saved us there. Forgot about that. You call the distress center, you call a friend, you call a therapist, you do whatever you need to do to stay safe in that moment. Because what you need to know is, if you're at the point where you're thinking about making a plan, that is, again, a huge red flag that there is something, some things, many things that are going on that are making you feel hopeless and helpless in that moment. But I need you to remember that that's a moment. That's a momentary thing. And that nothing is ever that helpless or that hopeless that thinking about killing yourself should be viewed as the ideal solution, okay? So reach out and call someone, go somewhere, find someone else, remove yourself from that situation. In and of itself, a lot of people experience suicidal ideation. Not as many people make it to actual acting, to actual behaviors, a suicide attempt. A suicide attempt is when a person engages in behaviors that are intended to cause death, but they do not. Now, the reason they do not is either they got it wrong, someone found them, or they changed their mind. Depending on what the method or the means of suicide are, that is a possibility. Sometimes the method or the means leaves it so that there is no chance to change your mind or for someone to find you before you actually die. Sometimes a suicide attempt is someone's attempt to ask for help. They engage in behaviors that are intended to cause death but do not because they haven't done enough of it. And I really hate this. I have to say, I hate that this is like gonna be on a recording that could be around for God knows how long. So I'm being very cognizant of not giving too much information, because should this fall into the wrong hands, I don't want this to be a how-to guide to suiciding. That's really not my intent here. So certainly during discussion, if you have questions about what I mean, I'll be happy to elaborate, but I am holding back a little bit with the awareness that you are not supposed to be circulating these videos. They are not supposed to live anywhere other than the protected site where they are, where the only people who can see it have to have a direct link to see it. So just know that if you have questions, I'm happy to answer them. I'm happy to give you more information, but I am very cognizant of that should this fall into the wrong hands, bad things can happen, okay? That's a weird sense of responsibility to have all of a sudden. I don't normally have that. I'm usually a little more cavalier about this. But sometimes a suicide attempt is truly a call for help. The person deliberately does not actually want to die, but they don't know how else to get out of the situation they're in. Sometimes it's the person really did want to die, but they didn't do enough of whatever they needed to do. And the first chronically suicidal patient or client that I ever had, that was just it. She thought she did everything right. And I only started working with her after her suicide attempt. I won't talk about her method, but she had done it on a weekend that her roommate was going out of town. So she knew that by the time her roommate came home, even if she somehow didn't things do quite right, she should actually be dead. What she didn't count on was that her roommate got to the airport, found out her flight was canceled, and came home and found her non-responsive and called an ambulance. So sometimes the attempt, and the client spent a week in a coma and then woke up and was pissed because she was like, what the heck? Right? Like, she was so sure that her plan was foolproof. And it would have been. If that plane had taken off, she never would have been my client. But the flight was canceled. And her roommate came home. Suicide itself, behaviors intended to cause death that do so. I don't think that needs any further elaboration. Now, the one term that isn't on here and that I want to introduce you to, it's not a term that I've really heard a lot about or read a lot about. It's something that I've talked about a lot, though, is this idea of suicidal fantasy. And I think a lot of people sometimes have thoughts of, what would it be like if I wasn't here? How would I kill myself if I was going to kill myself? So not at the point of ideation where someone's making a plan because they're in pain and they actually are thinking that they want to die, but kind of more of that, like, if I were to, this is how I would. And part of what spurs that on is I can remember being in grade 9, study hall in the library, and there were maybe 4 or 5 of us sitting around a table, and one girl said, if you were going to kill yourself, how would you do it? And I thought, what the fuck? I'm not planning on killing myself. Like, what type of question? This is study hall. This is not what I'm here for. But, we all go around the table, and sign of just how young and naive I was like, well, I guess if I were going to, I would just take all the money in my bank account, buy a lot of drugs, and have a really good time on my way out. Couple of fatal flaws with that plan. My bank account at the time had less than $300 in it. This was in the late 80s, early 90s when cocaine was actually still expensive, so that would have been a problem. But bigger problem, I had not a clue as to where to buy drugs, obtain drugs, how to use drugs, right? Like, I knew nothing. And to be honest, I still know nothing, except that a couple of years ago when I was running with a friend and she lived downtown, we were running down along the pathway by the river, and as we were under like the flyover, some guy, like, we're running, and he's like, you want some pot? And I'm like, what part of this suggests that we're in the market for marijuana? Like, we're running. And I was like, also, we don't have any money on us. Like, we're literally just out here running. So, but now you don't even have to go to like the underground. You can just go to the shop on the corner and pay more than what you would pay on the underground, apparently, for marijuana. But again, I didn't have a lot of money. Drugs were actually still expensive back then, and I had no idea where to source them. But that was my plan. And the reason I bring this up ties into your first reflection question, because I think there's so much stigma around the word suicide that I think people are afraid to even talk about things like that for fear that someone's going to be like, oh my God, you're going to try to kill yourself. We have to intervene. And so I wonder, and what I'm going to have you reflect on, I just introduced you to the term suicidal fantasy. What I wonder is, if we use that term more commonly and gave people space to talk about suicidal fantasies, what do you think would happen? All right, so you've had a chance to think about that, and I'm actually really curious to read your responses and to see what comes up in discussion That's not typically a question. Again, all the reflection questions are brand new this term. It's something I've never done before. Trying to think of like what prompts I might give in class or what directions I might give to discussion. So I'll be really curious to see how you guys responded to that one and what your thoughts are. So in terms of suicide and suicide attempts, women attempt more often, men succeed more often. This too is usually a place where we have some pretty rich discussion trying to figure out why that is, but I'll just go ahead and tell you why that is because this is the way we're rolling this year. Men tend to use more lethal means. So men tend to use things like guns and hanging themselves, things that do not allow them to be found before they're dead, things that do not allow them to change their mind. If you're holding a gun to your head and you pull the trigger, once you've pulled that trigger, there's no time to change your mind. If, on the other hand, you are using carbon monoxide poisoning or an overdose, you've got lots of time from when you start to when you would actually die to change your mind. There's also time for somebody else to find you and to call for help. And there's also a chance that you will do it wrong. Right? So that is one of the reasons that we see that men are dying at a higher rate. They have more successful, I hate using the term successful, more suicide completions, whereas women have more attempts. Now, also a little bit surprising, suicide rates tend to increase in older age. And you might be thinking, but we hear so much about teens and young adults and yeah. Old white men. Sorry, Ian. Ian is not an old white man yet, but he will one day be one. Hopefully, right? So, and the reason it's that specific demographic has a lot to do with our society and sort of the general culture that we live in. People of different minority groups tend to have more of a sense of community. And so what happens for a lot of older white men, if their wife happens to die first, they are left with nothing. And certainly I can reflect a little bit on my own family here and say that, my grandparents were of the generation and of the mentality, like my grandfather worked outside of the home, my grandmother kept up the house. And my grandfather was even a bit of an exception because he did do a little bit of cooking, but he had like his 3 things that he did, right? And that was it. But he could go to the grocery store, but he'd need a list from my grandmother. He wasn't the type to sit down and meal plan and think about what he needed and all that stuff. Laundry, I don't know if I ever saw him do. I certainly never saw him with a vacuum, right? So all these things that, again, it was the time. I'm not saying it's right or wrong. And this is the way he and my grandmother negotiated their relationship and their life together. But if my grandmother had died before him, he would have been left going, and now what? Right? He retired and unretired at least 6 times because anything more than a week of not working, he was going stir crazy. He needed to go back to work. So imagine he now is in his 70s or 80s. He's never had to cook and clean for himself exclusively. He's no longer working. And his children are all adults with their own lives and their own children, and his grandchildren have their own lives. And there's no internet. What does he do all day? Realizes how lonely he is. Realizes that, maybe he saw how maybe his wife, and again, this is fiction, this is not what happened to my grandparents at all, but how his wife suffered and was ill, and he's thinking, I don't want that, and I don't want to be a burden to anybody. And in fact, in some cultures, it's viewed as the honorable thing to do when you're old and not of use anymore to kill yourself, right? So we have to consider culture too, but we do see in North America, older white men are a bigger group for suicide because of the loss of connection, because of that loss of productivity. We think about Erikson's psychosocial development, and there's that late stage generativity versus stagnation. If you're in stagnation and you don't have people around you, what do you have to live for? Whereas oftentimes in some other groups, and I'm thinking particularly here of people who identify particularly as Black, there's the granny casserole parade, a widower So a male whose wife has died will never go without a meal because the grannies will take care of him. They will keep showing up with food or inviting him over. There's community, people who are involved with their church or their mosque or their synagogue or their temple have a sense of community and aren't alone. So that tends to mitigate the risk. Now, in terms of university students, because I know that obviously that would be of interest to you, about 12% of university students will admit to having had suicidal thoughts in the past year. My hunch is it's a higher number. I think people are afraid to admit that they've thought about suicide because they worry that someone's going to cart them off to the hospital. And about 10% of the 12% who've had suicidal thoughts will attempt suicide. So it's still a problem, and it's still something that we do need to be talking about. Okay? Okay, some of the risk factors. Whoops, okay. So some of the risk factors include things like a family history. So if you've had family members who have suicided, you may view suicide as a viable option because you've seen other people do it. Neurobiology, particularly serotonin levels, are implicated here. We do tend to see lower serotonin levels in people who have suicided. Again, though, correlation, not causation. Whoop, I keep doing that. I'm just so eager to get to reflection too. Existing psychological disorders. Now, I want to be really clear here. People suicide regardless of whether they have a mental health disorder, and the vast majority of people with mental health disorders do not attempt or commit suicide. So there's been this relationship over the years that I think has been exploited that's, oh, only people who are depressed suicide. False, 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 false. Yes, having thoughts of suicide is a symptom of depression, but people with anxiety suicide, people with eating disorder suicide, people with schizophrenia suicide, people with substance use disorder suicide, people who seemingly have it all suicide. Suicide cuts across every strata and every diagnosis. However, we know that people who do have existing psychological disorders are at higher risk of suiciding. But it's not just mood disorders, even though your textbook puts suicide into the mood disorder chapter. Don't touch it. And then the last one, look at how I stopped myself. The last one is stressful life events. So what we often see is that people will suicide after experiencing stressful life events. And this leads me to reflection number 2, that I've been so eager to get to. We are currently living through what can be described as a stressful life event with the COVID-19 pandemic. What do you think is happening to suicide rates? So if you were to compare the first half of 2019 suicide rates to the first half of 2020 suicide rates, what do you think it would look like? And that's the bonus, but not actual bonus points. Look it up. See if you could find stats comparing the first 6 months of 2020 to the first 6 months of 2019. And let's talk about it in discussion, because I think that'll be interesting. So let's talk about treatment for suicide now, okay? So basically, the main thing we're doing is we are treating suicidality directly. That doesn't mean that we wait to treat someone after they have committed suicide or have completed a suicide. Let's go with completed. But whenever somebody talks about suicidal feelings, thinking about completing suicide, we treat that. We work on reducing their psychological pain. We work on helping the person see options other than suffering. When you are mired in the shit that has you only seeing shit around you, all you can think about is, this is all my life will ever be. And what you need sometimes is a window washer to come wash away a little bit of that shitty window so you can see that there's something other than shit out there. We're not saying paint a picture of this whole, no. Little bit of hope and a little bit of reality that what the person is experiencing at that moment is not their forever reality. That helps the person see options other than suffering. And of course, we want to encourage the person to pull back from the self-destructive act. Do keep in mind, you are undergraduate psychology students. If someone tells you, yeah, I've got a gun and I'm going to shoot myself, it is not your job to talk them down. Absolutely, if you can be supportive, be supportive. absolutely text someone while you're talking to them to call 911 and get them to their location, right? We want to encourage the person to not complete it, but know that if you ever find yourself in a situation where somebody has told you they're thinking about suiciding, you have done everything you can to help them, and they still do it, it is not on you. It is not your fault. They have chosen to do that. Okay, that's a really important thing, particularly if you're going to work in mental health. I had one grad school prof who told us, if you're going to work as a clinician, I can guarantee you two things. You will get sued for malpractice at some point, and you will have a client suicide. We can't prevent everything. We do our very, very best, but that's all we can do. We also want to think about targeting people who are at risk. So when we think about those risk factors, that a family history, the neurobiology components, if we know someone has been taking a serotonin boosting medication and has stopped, and we see them sort of starting to slide back into despair, we know that we have to work on that. If they have existing mental health disorders, if they have a series of stressful life events, let's focus on getting to them before they think about suicide. Let's give them some more coping skills. Let's give them some more support. Let's give them some respite if that's what they need, okay? And then, of course, suicide prevention centers, things like 24-hour hotlines offer some help. Again, in the contacts list on Blackboard for this class, the phone number for the distress center is there, as well as the URL. The distress center, there is someone there 24/7. No call is too small. You can always reach out. And similarly, you can always call for emergency services if you or a loved one is in danger of doing something that you may later regret. Okay, I said we were going dark before. Now we're going really dark. I want to talk to you a little bit, but really I'm not going to do a lot of talking. There's going to be a lot of links for you to go look at that I'm not going to take you through right now, but we will talk about both of these cases in our discussion groups. I want to talk about two suicides in the media, and I'm not talking about famous people. I'm not talking about anything all that historical, but these are two young women in Canada who have suicided for two very different reasons, but I think they're both important to address, especially when we're talking about mental health disorders. So the first one is Rehtaeh Parsons. Rehtaeh, so you'll read about Rehtaeh, and then you'll watch a couple of short videos, and then I just threw up the Wikipedia link too, just for funsies, because Wiki is an okay place to get sort of an overall picture. It's not the definitive site, of course. But Rehtaeh was a young lady who lived out in the Maritimes. This was a couple of years ago. She had too much to drink at a party, and she was allegedly gang raped, and the boys took pictures. And she was then mercilessly bullied on social media and at school to the point where she had to change schools. None of the boys faced any consequences until after her death, at which point they were charged, but not with rape, but with basically child pornography, because she was underage and they had taken pictures. For what they did, allegedly, again, I'll say allegedly, but it seems pretty clear what they did, to Rehtaeh, and her consequences were that she just couldn't cope. And this is someone, again, an example of someone who was getting support and love and psychological treatment, but the treatment of her by the media, by her fellow students, was absolutely abhorrent. So I want you to learn a little bit more about Rehtaeh. And then I also want you to learn about Ashley Smith. Ashley Smith was 19 when she committed suicide in an adult federal penitentiary for women in Canada. And the result of the inquest into her death is that they ruled her death a homicide. Guards were standing outside of Ashley's cell and did not go in until after she stopped breathing. They did not try to intervene. The videos of Ashley, they're short, but they are hard to watch because there's actual footage from the jail. But I think it's important. These are stories that are true. These are things that have happened. We often hear about, when we hear about someone like Kurt Cobain suiciding, it's like, or any one of a myriad of rock stars who have suicided. We're sad, but they're a celebrity and it's the US and blah, 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 blah. Rehtaeh was a kid at a party who had too much to drink. Ashley Smith first got into trouble with the legal system for throwing crab apples at a mailman and ended up suiciding in a federal penitentiary. We need to know their names. We need to know their stories. We need to talk about this. So watch these. I've warned you, they're really disturbing. There is a reflection question that's going to come up after these. So I'm going to go ahead and move to that now, but we will talk about these in discussion. And so here is reflection question number 3. After learning about Rehtaeh Parsons and Ashley Smith, are you okay? What can you do to take care of yourself at this time? And a reminder, information for MRU counseling services and the Distress Center are on Blackboard. No call is too small. If you need support or just a listening ear anytime, 24/7, call 403-266-4357.